Why do we need to look at the carotids at all? The reason is stroke. Stroke is a leading cause of adult disability. 80% of strokes are ischemic strokes. Only 20% of them are hemorrhagic. And 50% of strokes come from extracranial carotid emboli. And therefore, we need to look at the extracranial carotid very carefully. What is the warning signal? The warning signal is transient ischemic attacks, or TIAs, and those are pretty much the features of TIAs. It suffices to say that TIAs are due to embolic showers from the carotid bulb most often, which cause subliminal damage. The other half of the origin comes from the heart. So what are the indications of a carotid Doppler? Transient ischemic attacks, transient monocular blindness, reversible ischemic neurodeficit, stroke, which is mild or resolving deficit, especially those at the younger age groups, retinal artery or venous occlusions, as they are referred from the ophthalmologist, asymptomatic carotid bruits, post-op endarterectomy to look at the patency of the vascular segment, pre-op coronary bypass, pre-op peripheral vascular disease surgery, so on and so forth. And now, of course, you have intima medial thickness, which is coming up as a screening modality. The etiology of carotid disease could be any of these, but the end result is luminal narrowing or occlusion, and that is what carotid Doppler will show us. Now, why do we need to do? What is the aim? What is the end we need to achieve by doing a carotid Doppler? We need to classify patients as those without significant disease, those with mild disease, and when we say mild, we mean any narrowing lesser than 50% diameter reduction. Lesser than 50% diameter reduction is mild disease, because mild disease means medical treatment alone, or whether they belong to the 50 to 70% diameter reduction, in which case medical treatment with follow-up, especially if symptomatic, or this is the most important category, or if they belong to greater than 70% diameter reduction, and this is the category where surgical intervention really, really helps. So if I'm able to tell the referring physician or clinician as to whether it is a sub 70 or above 70, I would have done my work in terms of a good report. Total occlusion, however, means no surgery. So this is the aim as such when we go through the carotid Doppler. That means to say our report at the end of the day should tell the surgeon whether it's 70% above or 70% below. Instrumentation, we saw all this. We will not go through this again. Patient position, we saw anterolateral, posterolateral, we saw examination protocol, we saw get oriented, and what I need to say is that record angle corrected velocities. Angle correction is very important. The steering is very important. Keep the angle as low as possible. Definitely it should be below 60 degrees, lesser the better. We need to measure velocities at standard levels and also at levels of plaques and stenosis. Very, very important. Standard levels and levels of plaques and stenosis, and determine vertebral flow. No carotid examination is complete until we finish with the vertebrals, both by color as well as a documented velocity waveform with angle correction. Okay, now where do we do the standard velocity measurements? The standard velocity measurements are done in the common carotid artery about 2 to 3 centimeters proximal to the bulb. So the bulb is indeed the dilated portion or the origin of the internal carotid artery. So CCA about 2 to 3 centimeters proximal to the bifurcation. Then do it at the carotid bulb, and then at the internal carotid artery about 1 centimeter or 2 distal to the bulb. You can also if you wish to do an external carotid artery recording as well. Remember, the sample volume is always small. It's lesser than half the diameter of the vessel. Central placement in the lumen and Doppler angle is always kept as small as possible. That's the value of a transverse scan. That's the value of a transverse scan. You need to go up and down. That's the bulb and the external internal join to form the bulb. So actually I'm scanning from the base of the neck. You see the two different vessels, and as I bring the probe down, they merge into one, and you will see the plaque in the internal carotid, not in the external carotid. Now, the commonest areas from where embolic showers can emanate are the CCA origin and the bulb, and between the common carotid origin and the bulb, it's the bulb which is more important, and this is the site of atheromatous involvement. The origin of CCA can be a difficult proposition on the left side. On the right side, yes, you have the brachiocephalic artery which splits into the subclavian and the common carotid, but the left common carotid starts off from the aorta, so demonstration of the origin on the left side may be a difficult proposition. A few words on the vertebral. We missed this out on the live demonstration. We need to look at the common carotid artery longitudinal anterior approach, move the transducer laterally, and as we do it, look for the transverse processes of the cervical vertebrae. They are echogenic areas with shadowing, and look at the gaps in between. So the vertebral artery is seen in between these gaps between the transverse processes of the cervical vertebrae, and having seen them well, you can turn the color on, do your angle corrections, and take the velocity representative sample. That's a clip. We'll skip that. We'll skip this. Internal carotid, low pulsatility. External carotid, high pulsatility. Internal carotid, larger, shows the bulb. Smaller, no bulb. No branches, branches. Low peripheral vascular resistance, high. And no temporal tap, temporal tap. We'll see a few of this. Okay, that's the bulb there. And that's the waveform. Low pulsatility, high pulsatility. No notch there. Presence of notch there. And that, we saw that. If I take that off. And this is the value of a branch. If you have problems, you can show the branch. That's the external carotid. This is the internal carotid, because I know the internal carotid doesn't give off a branch in the neck. So these are tricks and ways to actually look at or distinguish between ECA and ICA. We'll skip this. We did this on the demonstration. This is just to show the laminar flow which we discussed. And this is what is the temporal tap. So when we tap on the superficial temporal artery in front of the tragus, you get these small little jiggles which happen especially on the diastolic phase of the waveform. Can you see this undulation? Small undulations. Whereas here onwards, I've stopped tapping the superficial temporal artery. And what happens to the jiggles? They disappear. So I know the vessel I'm sampling is the ECA. Okay, that's CCA. CCA is a hybrid. It feeds both the ECA and the ICA. So therefore, the waveform it betrays or it shows is indeed a hybrid. It's a mixture between high and low. Bulb, as I said, we will look at the bulb a little later as far as the waveforms go. That's ICA, which is low velocity, a low pulsatility, and a low peripheral vascular resistance. This is ECA. And then, of course, color voids can happen if a vessel is tortuous. If a vessel is tortuous, why is this happening? Why is there no color there? There is blue there, there's red there, but there's nothing between here. Angle, because the angle is 0. And at 0 degrees, the Doppler shift, the angle is 90 degrees. Therefore, the Doppler shift is 0. When the angle of inclination is 90, when I'm attacking or looking at a vessel perpendicularly with Doppler, the angle is 90 degrees. Therefore, the Doppler shift is 0, and that is why there is no color encodement over there at all. B-flow helps. B-flow doesn't overwrite, whereas color overwrites. We saw that in yesterday's presentation. Carotid bulb is a very, very interesting area of the carotid. It's a club-like dilatation of the ICA origin. Velocity slows over there, and slowing of velocity can be seen both by color and spectral Doppler. flow separation occurs, and that's due to vortex flow, and the vortex flow is on the side of the bulb opposite the ECA origin. Early and mid-systolic phases is where you get the flow separation the maximum. It occupies 33% of lumen diameter, 22% of cycle length, and that is the area which is prone to plaque deposition. So that is why we need to know about this very unique phenomenon of flow separation in the carotid bulb. That is where plaques deposit, and always measure ICA velocity about 2 centimeters distal to the bulb. The bulb does not reflect the true velocity of the ICA because it's a dilated segment. The true velocity comes up only distally. So that's very important. So that is the bulb, and that is the vorticial flow. The flow actually comes back and goes in the reverse direction, and that is the region of flow separation, which is opposite the flow divider. That is the flow divider. This is opposite the flow divider, and that is the area where the plaque deposition is most common. And when plaque deposits, what happens to the flow separation? It disappears because the dilatation is converted into a cylinder. Okay, so that is how the flow separation looks. That's what we saw in the demonstration a little earlier. That's a real-time clipping, and this is how flow separation looks on spectral. So mid-systolic, reverse flow. That's the systole, and bang, in the mid-systole, you have a flow reversal, and that can be controlled. Your waveform appearance can be controlled by where you put your range gate. You can put it only in the blue, where you will see only reverse flow. You can put it only in the red, where you will see forward flow. You can put your range gate a little bit on the blue, a little bit on the red, and you will see something like this, which happens. So that's normal. It's a normal phenomenon. Loss of flow separation occurs if there's a plaque in the carotid bulb, as in this particular case. So what's the carotid anatomy? Anechoic lumen, intimal reflection, medial hypoechoic thickness, adventitial hyperechogenicity, tube bulb dilatation, tortuosity. We saw this in the morning, but it's just to recap. That is the intimal reflection, that thin white line. Then this is the thickness of the tunica media, isn't it? And what comes outside of media? Adventitia. So that hyperechoic layer is adventitia. This is tunica media, and this thin delicate line is tunica intima. It's not the thickness of the intima, it's just the reflection from the intima. The intima is very, very thin. It's a single endothelial layer. A single endothelial layer cannot produce a thick line on ultrasound. We're not doing microscopy. It is just the reflection which is seen. It does not represent intimal thickness. That's the longitudinal. This is the transverse. So you see pretty much the same anatomy over here, all the three layers, over there to a certain degree. But what happens to the anatomy here and here? Why is it not seen? Perpendicular. This anatomy is seen only in regions of the carotid which is perpendicular to the line of transmission of ultrasound. Here it's tangential, so you don't get to see it. If you want to see this, you'll have to flip the probe and look at it from the lateral approach. Then you will see the lateral walls well. Okay, what's an atheromatous plaque? It's a deposition in the tunica media. As it's deposited in the tunica media, the intima is elevated, and therefore there's a projection into the lumen, and this presents as a color flow void. You can look at a plaque in terms of its echogenicity, in terms of its size and extent, and in terms of its surface characteristics. We'll see a little. Those are pathological pictures. So we'll go to the picture straight away. Okay, now let's look at this carotid bulb. Anything much? Don't read what I've said there. Look at the lumen. Is there anything striking you in the lumen? When I turn color? Yes, that's a plaque. So some plaques, believe me, are hypoechoic. And they are predominantly fatty plaques. Not much of fibrous tissue, a lot of fat over there, and that can be a pitfall. Color brings it out beautifully. That's a hypoechoic plaque. On the other hand, look at this. It's so easily seen. That's the adventitia. That's the intimal reflection. This is the media, and it's fairly an echogenic plaque, and that's easily seen. More of fibrous tissue, fibrofatty plaque. This again is homogeneous. There's a smooth elevation of the intima, and all along it looks absolutely homogeneous. Again, a fibrofatty plaque. On the other hand, let's look at this plaque. It's irregular. There's a pit over there. There's a pit over there. Again, it looks gnarled. I'm not very happy with the plaque surface over here. Plaque ulcers can be diagnosed, but we need to be very, very fastidious before we say it's an ulcer. Let's look at this particular plaque. Is it a plaque? That's the adventitia. This is the intima. Yes or no? You agree it's a plaque. Now let me look at the intima. Is it continuous here? There is a break. So I need to demonstrate a discontinuity in the intimal surface. And when I do a color Doppler, the color should extend into this pit, and the pit is all around, surrounded by the plaque. Only then can I diagnose a ulcer. Plaque ulcer is important to diagnose because it means trouble. It means this is a very, very embologenic area in the anatomy. Okay, that's a homogeneous plaque again, and that is intraplaque hemorrhage. You see the plaque there, and you see these little dark foci inside? That's intraplaque hemorrhage, and that means trouble again. So homogeneous plaques, I'm happy, but once there are foci of hypoechogenicity, that means we are possibly dealing with hemorrhage. That, of course, is a calcific plaque. Okay, now how do we look at the size and extent? You need to look at the length of the plaque and the thickness of the plaque. Thickness of the plaque is best done in the transverse view. The transverse view also tells us what diameter, what circumference of the vessel is the plaque involving, whether it's a circumferential plaque all around or a non-circumferential plaque occupying only one part of the circumference. So that's the length and thickness, but as I said, the thickness is best measured in the transverse. So you know clearly that, yes, this is a plaque which is not extending even to the half. It's about quarter the circumference of this particular vessel. Okay. Again, plaque, again, half the circumference. Half is open, the other half is occupied by the plaque. Again, that is the residual lumen. Okay, now, what are the pitfalls? Color bleed, spurious blood flow voids, off-center longitudinal. There are many pitfalls for a plaque, and it would take a little longer time if we have to discuss each of these in detail, but we need to know that we have to be careful when we look at the size, the extent, and the surface characteristics. Okay, whatever be the nature of the plaque, fatty or fibrofatty, whatever it is, the effect is due to narrowing or occlusion, and it's due to a decrease in flow or no flow. Pressure drop occurs from 50% diameter reduction onwards. So lesser than 50% diameter reduction, we don't see any systolic jetting. We don't see any systolic elevated flows. It only starts after 50% diameter reduction. Mark my words again, it's diameter reduction, because you can also quantify stenosis in terms of area reduction. Diameter reduction is not equal to area reduction. 50% of diameter reduction is equal to 75% area reduction. So in our reports, when we report, we need to say what kind of stenosis or reduction are we thinking of when we are reporting diameter reduction 50%. So the degree of stenosis is more important than the length of the stenosis, as we can learn from the Poissonier's law. Embologenicity depends upon the surface characteristics as well as the presence of stenotic jets. Now, how do we quantify the degree of stenosis? You can do it on the basis of grayscale imaging quality. If my grayscale imaging is excellent, as I showed you some teaching pictures are the best you have. Not all patients give you such beautiful pictures, believe me. If your grayscale pictures are excellent, you can directly measure. But if they are suboptimal, you might need to look at velocity criteria for diagnosis of the degree of stenosis. No, we will not go into the details. Direct visualization, simply measure the whole area, then measure the area of the lumen alone. Measure the area of the lumen alone and make a ratio there. That will give you make a percentage there. That will give you the percentage of area stenosis. Area stenosis, not diameter. Area stenosis. Waveform criteria, very, very important, because more often than not, we depend on velocity criteria rather than direct measurement. Now, what do we need to do here? We need to look at the systolic, peak systolic velocity. The peak systolic velocity, or the PSV, is increased at the site of stenosis or just beyond the site of stenosis. That's very, very important. Also, there's increased diastolic velocity, especially in high-grade stenosis, 80% and above. Spectral broadening, sonic window filling. So you can look at color criteria. You can look at audio criteria as well. The audio signal becomes very, very rasping. So you have the waveform criteria, the color criteria, the audio criteria. We'll see a few of these. So let's look at this clip. Okay, that's definitely narrowing out there. There's aliasing, there is systolic jetting, and you have a lot of color spilling outside of the vessel. What are all these speckles happening outside? That's the color bruit. Remember, whenever there's a tight stenosis, there is so much of vibration around the vessel that the tissue which is vibrating begins to give those color speckles. So that's typical of a color bruit. And when you do an angle corrected velocity measurement, you will find very, very high systolic. Is the signal heard as well? It's a rasping signal. It's a very, very rasping signal. It's no longer musical at all. You see those high velocities systolic. You see the diastolic velocity is also high, 340 and odd, very, very high. The color helps us to position our angle correction beam. That's how we use the color there. We need to know where the jet is. The color tells us, look, here is the jet. It also tells us, look, this is the direction of the jet. So you position your angle correction beam accordingly. So we realize that greater than 50% stenotic lumen only gives rise to increased velocity. So maximum velocity is seen at the region of maximum stenosis or just beyond. Color helps us in choosing the best sample site, and it also helps us in accurate and consistent angle correction. The parameters used, as I said, PSV, end diastolic velocity, and velocity ratios. Remember, sometimes the jet need not be parallel to the vessel wall. It can be at an angle. So we don't have to follow the vessel wall parallel correction at all. You have to look at the jet and correct it according to the jet. Now, a word on velocity ratio, because it's a very, very important concept. Velocity ratio can be done either for systole, peak systolic velocity, or end diastolic velocity. Velocity ratio, let's take the example of peak systolic velocity ratio. It is the peak systolic velocity at the site of maximum stenosis divided by peak systolic velocity proximally taken from a normal segment. So when we do this, how much time do I have? Am I overdoing it? I have another 24. Okay, okay, fine. So, yeah, thanks. Okay, so it's PSV ICA, PSV CCA most often, because we know that the bulb is the area of maximum stenosis, ICA, divided by PSV CCA. Why do we do this? Why do we need velocity waveform? Why do we need ratios at all? We can just take the peak systolic put it on a table and say, yes, it's more than 70, less than 70, or not even 50. Why do we need this? Because absolute velocities are so variable in the human population. The absolute velocities measured depend on the pulse rate, the blood pressure, the cardiac output, peripheral vascular resistance, the compliance of the vessels, so on and so forth. So if we have to negate all these factors and compare one velocity of a patient to another velocity obtained from the same patient, we actually nullify the effects of all these physiological influences. So this is a graph just to show us that as the degree of stenosis increases, this is 0%, that's 100%. As the degree of stenosis increases, the velocity begins to climb. But the climb starts where? 50%. Below 50%, not much of rise. At 50% and beyond, there's a rise which goes up. And actually, once you cross 90-95%, the flow actually falls. And total occlusion, the flow becomes 0. So that's example of a stenotic jet. The eccentric jet over there. The jet is not in the center of the vessel. It is close to the side of the vessel. So color helps us to put our cursor there and not elsewhere. Okay, that's the velocity waveforms obtained. Now this is a absolute velocity table. So if I get a velocity greater than 250, I would grade this as 80 to 99% diameter stenosis. If it's greater than 130 centimeters per second, I would grade it as 60 to 79. But believe me, this is not the best way of doing it. And therefore, we look at the systolic velocity ratio. And the systolic velocity ratio, if it is above 3.7, means it is 80 to 99% diameter stenosis. A very, very simple way to do it actually is to look at the Robinson et al. Criteria, which says that 50% stenosis, you are looking at an IC-CC ratio of 2, and if it's 70%, you're looking at 3. It means to say that if your velocity at the region of maximum stenosis is double that of a proximal normal segment, you're dealing with? Yes. And if it is treble, you're perhaps dealing with 70%. So this gives us the criterion for 70% diameter stenosis, and it's a very, very useful thumb rule. So that's a calcific plaque, that's a very, very high stenosis, and look at the velocity. End diastolic velocity is more than 100 there, and when the end diastolic velocity goes more than 100, you know it is 80 to 99% diameter reduction. And distally, of course, you have the Tardis Parvis waveform. Now, this is a case of this is a case of carotid bruit for evaluation. You see that it is the right external carotid artery which is narrowed. The internal carotid artery is not narrow, and therefore that's good news for the patient concerned. Okay, now an important thing is to distinguish between total occlusion versus trickle flow. A trickle flow means that there is a lumen which is there, but this lumen is so narrow that flow is just a trickle, versus a total occlusion, and that we need to talk to the machine, bring down our settings as for a venous, because we don't expect sky-high velocities over there. A trickle flow is a slow flow, so we have to reset our machine to look at slow flows and then demonstrate that yes, indeed, there is some flow which is happening there, or no, there is no flow, it's a total occlusion. We'll see one or two instances of total occlusion, and then I think we will close because this lecture can go on a bit longer. So that's what happens if there is a CCA occlusion. If there's a CCA occlusion, the external carotid can collateralize into the internal carotid. That means the external carotid, instead of taking blood away, it can't take blood away because this is clogged up. So the external carotid puts blood into the internal carotid. And that can be shown by Doppler very, very elegantly. Let's look at this clipping there. Okay, that's the LCCA. What about the LCCA? there is total occlusion. Okay. Now we'll go on to the, okay. Now that is a vessel which is giving you a branch. Did you see the branch there? So that is what vessel that was? ECA was in what color? Red, isn't it? Whereas ICA is in blue. That means blood is entering towards the probe and then away. So ECA is putting blood into the ICA, in this case of common carotid occlusion. So color Doppler can sort out the dynamics, hemodynamics. Now let's look at what happens if it's an ICA occlusion. When the ICA is occluded, the common carotid artery will only supply the ECA, and therefore if I take a common carotid artery waveform, it will be similar to that of a ECA. So even if I haven't reached the ICA, the fact that I have seen an ECA waveform in the common carotid artery itself tells me that there is possible occlusion in the ICA, and that is called externalization of the CCA waveform. Let's look at a case example. That's an RCCA, right common carotid artery, and in the right common carotid artery, I'm able to show a very deep notch, a very high pulsatility. So the RCA is not supposed to look at this, but this is the situation. So I would suspect a distal ICA occlusion, and fair enough, sure enough, when I go towards the bulb, there is a thumb flow, and when I get into the RICA, there is no flow. So that's externalization of the common carotid artery waveform. The factors which affect the waveform could be local atheroma tortuosity, proximal to the site of sampling, which is a CCA origin disease or aortic valve disease. It could be distal due to intracranial siphon disease or intracranial vascular disease. It could be remote due to contralateral occlusion. It could be physiological due to high cardiac output. Now that's the Tardis Parvis waveform in the ICA. Why? Because of proximal. Because of proximal occlusion. This is a vertebral artery showing you a triphasic waveform. Vertebral also should be a low peripheral vascular resistance. So therefore, I know this is a distal occlusion, and the vertebral is now just acting as a muscular artery, and therefore it has got these waveforms. That's an aortic incompetence showing you a very, very deep reverse diastolic component in the CCA. So that is how we look at these waveforms. We will skip collateralization for the want of time. Okay, vertebral artery also can be narrowed, can be occluded. There can be vertebral steal phenomenon. That's the subclavian artery origin, which is stenotic. That's the subclavian artery origin, which is showing sky-high velocities there. That's this. Oh, Dr. Nitin did this, so let's not waste time. That's reverse diastolic flow, in the reverse flow in the vertebral, showing a steal phenomenon over there. Vertebral artery can be stenosed, and the same stenotic criterion work. There is systolic jetting and turbulence. That's the vertebral artery occlusion happening over there. Post-endarterectomy, you can show the endarterectomy segment, anechoic, absent intima, and you can show Doppler-wise that there is a fill. That's a stent. You can see the texture of the stent beautifully brought out. You can, color Doppler can show stent patency. That's the texture of the stent over there. So that is how we can use a color duplex Doppler for basically looking at wall pathology, looking at whether there is a stenosis, looking at the fact whether it's a trickle flow or an occlusion, looking at the vertebrals and taking it forward as to below 70%, more than 70%, and this is a very, very good screening modality. Thank you again for a patient listening. Thank you.